Well, maybe you remember this slide from the yesterday's presentation in the course. Remember that any person with a fatty liver may have a non-alcoholic fatty liver disease, provided you have discarded a number of secondary fatty liver disease. Probably if there was any hepatologist here, he would list HIV as a cause of secondary fatty liver disease. And he'd say, guys, you're wrong. You can't talk about NAFLD in HIV. It's a contradiction. However, probably hepatologists are not aware of this. This is something you're experiencing every day with all patients starting ART. As soon as you treat them with effective therapy, they start to gain weight. They start to gain weight till they reach their HIV-negative counterparts, and they soon catch the obesity epidemic. The general population is suffering. So, yes, there is NAFLD in HIV infection. I will go through all these aspects. I'll begin with some studies on the frequency of the problem, less studies on the natural history and risk of progression of NAFLD, and factors associated with the steatosis, metabolic risk factors, the possible role of antiretroviral therapy, a little bit on genetics and management. So let's begin with prevalence. First studies on the prevalence of steatosis in HIV came from liver biopsy-based studies. These were cross-sectional retrospective studies performed in patients who were selected to undergo a liver biopsy because the clinicians were thinking about treating them with interferon, probably. And in that setting, there might be some sort of a selection bias. The rates of steatosis were as high as 70% to, in the lowest range, 40%. In those studies, the associations were, some are summarized here. You can see a strong signal coming from D drugs that we don't use anymore, but here is, for example, a case for secondary fatty liver disease in HIV. But then, next row, metabolic factors, BMI, weight, triglycerides, fasting, plasma glucose. This is NAFLD. And then other secondary cause, in some studies, genotype 3 and Hep C. Well, in more recent years, we were able to perform a screening using non-invasive techniques as CAP. And we found this in this prospective cross-sectional study in Spain among 505 patients, and using CAP as screening method with this threshold, 230 decibels per meter, we found that 40% of this population had steatosis, something that reminds you on what was found in liver biopsy studies. So we were finding something that was in agreement with previous results. There were some signals of associations with drugs. We were not using D drugs, but there was an association to lower frequency of steatosis for those on nevirapine, on raltegravir, on maraviroc, and even on ritonavir-boosted protease inhibitors, the modern ones. And then we saw this. Overall, obesity, body weight, BMI, this is the main predictor, the main factor associated with steatosis in HIV. If you move through these categories of body weight, overweight, obesity grade 1, obesity grade 2, you see this nearly perfect correlation. So this is NAFLD. But what is this? There are people with normal weight 26% of them that show steatosis. There's something there that might not be metabolic. But when we made our multivariate analysis and put in all the univariate associations, including many metabolic factors that you can see here, finally only BMI stand up after the analysis with a very, very strong association with steatosis. So in this setting is NAFLD essentially what we were seeing. Other studies using a similar design, cross-sectional, prospective, based on CAP, as this German experience, showed very, very similar results. 41% of the patients, in this case, they selected mono-infected patients out of these 364 population. They excluded mild alcohol intake from their analysis, and they found a nearly the same rate as we found initially, and also BMI as the strongest factor, but also triglycerides and glycated hemoglobin. And then another study from the other side of the sea, coming from Canada. In this single center study, they used the newly proposed cutoff of 248 decibels per meter to define steatosis, and they found that 36% of the overall population showed steatosis. In a previous study in 2016, the same group showed that using the other cutoff, 238 decibels per meter, around 48% of their population showed steatosis. So all studies seem to agree, even those coming from the Americas, where they have bigger people. And again, the independent associations were the same, BMI and triglycerides. So, summary for prevalence studies. Frequent problem, 35 to 40% of unselected populations. The main factor associated with steatosis is metabolic factors, and it is BMI, NAFLD, and maybe there's some sort of relationship with other drugs, not the drugs, but maybe there's a role for metabolic-friendly drugs. We don't know. Now we move on to natural history and the risk of progression. Let's go back to the Stone Age of liver biopsy. In this paired liver biopsy study, patients were selected because they have undergone an initial and a second liver biopsy separated by a median of 3 years. And what you can see here, these are co-infected patients again, is that the initial steatosis frequency was 40%, and it was nearly 70% by the end of 3 years. And importantly, there was an increase also in grade 2 and 3 steatosis, in more severe steatosis. Indeed, very few patients showed regression, and 36% progressed at least 1 grade, 5% progressed 2 grades of steatosis. Well, we found something expected regarding antiretroviral therapy. The longer the period you expend on the drugs, the more likely you progressed, you find steatosis progression. But then, surprisingly, perhaps, the same behavior was found for efavirenz. Then we looked back at the literature, whether there was something, and we found that there was in vitro data showing that efavirenz might have mitochondrial toxicity through an independent pathway, and a pathway independent from DNA polymerase. On the contrary, other drugs, as 3TC, didn't show this behavior, and nevirapine even showed a contrary behavior with decreasing tendency of progressive disease. Finally, in the multivariate analysis, the efavirenz signal was lost. Probably this could be due to the use of efavirenz together with D drugs. We don't know. Only D drugs and the metabolic factor, is fasting plasma glucose, were associated with the risk of progression. But in addition, we could see what happened with NASH, because we had biopsies. Remember that you can only diagnose NASH if you have a biopsy. We used the NASH score, which is the sum of these three items, steatosis, lobar inflammation, and ballooning. And we saw that a great proportion of patients showed increases in NASH, 45% of the patients. However, when we were more strict and looked at the diagnosis of NASH, that is a NASH score equal to 5 or greater, there were 16% patients with NASH initially, and in the final biopsy, 18%. But look at this. A few of these initial patients showed persistent steatohepatitis, but this is something to worry. Some of the patients without steatosis progressed to steatohepatitis, so finally they sum up 18%. And what's more important, the persistence or progression to steatohepatitis, to NASH, was associated with fibrosis progression. So this is bad for people. What about non-invasive techniques? Well, you can enroll far more patients than in liver biopsy studies, in this case 326 patients. And what we saw was that through a short period of time, 1 year, there was an overall inapparent change in median CAP values. There seems to happen nothing, no progression. However, when we looked at specific groups of patients, for example, patients with increase in their BMI, patients with increase in the fasting plasma glucose, increase in triglycerides, there were increases, significant increases in the CAP values by the end of follow-up, okay? And in the same sense, patients with patients with an HIV RNA, undetectable HIV RNA without, showed also that behavior. On the contrary, patients that were treated with RAL, here, you can see, yes, RAL decrease in the final CAP values. So this was some sort of paradox. When we adjusted this in the multivariate analysis, guess what? Only BMI predicted changes in CAP. This is the second part of the Canadian study I showed you before. Here they analyzed 232 patients with, that had some CAP evaluation after baseline, and they defined steatosis progression as a change in the CAP threshold of 248 or transition to greater than 292. They found again BMI, not surprising, but also an association with Hep C co-infection. Patients with Hep C co-infection were less likely to show progression to steatosis. We didn't find that. In the German study, they didn't find any difference between patients with and without HIV, Hep C co-infection. What's more important, they found that patients with any degree of steatosis, this line in blue, progressed, the liver stiffness progressed over time. And that was an independent factor for progression among patients without Hep C infection. So this is very important because this set the scenario for progressive liver disease. But we don't have a complete picture of NAFLD, or the natural history of steatosis is incomplete because we lack studies with hard clinical endpoints. For that, we need a longer period of follow-up. Remember, 17 years or more in the study I presented yesterday on the effect of liver fibrosis on liver-related death. So maybe we need more follow-up of patients. But we know now clearly that BMI, again, metabolic factors are associated with the progression of the disease. We don't know what's happening with efavirenz or integrase inhibitors. That's why we designed a specific clinical trial to try and disclose what was the relationship between antiretroviral therapy, specifically with efavirenz and steatosis. We looked at changes in liver steatosis after switching from efavirenz to raltegravir. This was a randomized controlled clinical trial. We selected patients that had steatosis according to this CAP value. Patients had to drink less than 50 grams per day for men and 40 for women, and had to have a controlled HIV disease with an efavirenz-based regimen with Truvada or Coinfection. Then we randomized patients one-to-one to switch efavirenz to raltegravir and maintain the same 2-nuke backbone, or to continue with the efavirenz plus 2 nukes regimen. Patients were evaluated at baseline with CAP at 24 weeks and 48 weeks. These are the main results of the study. In blue, you can see the efavirenz group showing an increase in the median CAP values till 48 weeks, and in red, the RAL group showing a decrease in the median CAP values until 48 weeks. And these median CAPs, by the end of follow-up, were significantly different. What I believe is far more important than changes in a continuous variable is this. Remember, these patients were selected because they had steatosis as classified by a CAP value above 238 decibels per meter. So these are the rates of patients going down that threshold, going below 238 decibels per meter, 48% in the RAL group and 15% in the efavirenz group. Now we have some data indicating that the negative predictive value of this threshold is 95% or so. So we might be really, really sure that these patients don't have steatosis. And that happened despite, by the end of follow-up, patients on RAL had a nearly significantly higher BMI than those on efavirenz. So what is this? Well, clearly the drugs are highly steatogenic, but that doesn't matter, we don't use it anymore. But other antiretroviral drugs might also be steatotoxic. There were some signals in previous studies that were mainly obscured by the big effect of BMI. But steatosis can regress after switching to safer and less toxic drugs, for example, efavirenz to RAL. So, a couple of words about genetics in HIV. The adiponutrin gene, the PNPL3 gene, is the major genetic determinant of NAFLD in the general population. However, we have contradictory results in HIV infection. In the MAX cohort, these variations were related to steatosis in HIV-infected MSM, but not among HIV-uninfected MSM. But then this result was not replicated in other HIV larger studies, and there was a lack of association with this between NAFLD and these variations in HIV Hep C co-infected patients. Maybe we need a GWAS, a genome-wide association study specifically designed to target HIV-infected patients. we're finishing. Management. Management of NAFLD and of fatty liver disease. We have two problems here. Of NAFLD, target metabolic factors, essentially obesity, because type 2 diabetes and dyslipidemia will also improve if you are able to decrease the weight of your patient through diet and exercise. But then, remember, review your antiretroviral therapy, the treatment the patient is exposed to, because there might be something to change there. To conclude, steatosis, and this is mainly NAFLD, is frequent in HIV infection and can induce fibrosis progression. Factors associated with steatosis in HIV infection are mainly metabolic, so this is true NAFLD. I'm keeping in mind antiretroviral drugs, as I've just said. Perhaps there are some specific background, genetic background here, we don't know. And management is exactly the same than we discussed yesterday for HIV and infected people, plus reviewing art. Thank you for your attention. Thank you all these people for helping me to produce this data.